Okay, for our last talk of this session, we're going to talk about the difficult ERCP and getting into the inaccessible duct. You've heard a lot about pancreatic endotherapy, but obviously that involves getting into the right duct. It's my pleasure to have Dr. Janak Shah, who's Director of Pancreatico-Biliary Endoscopy at the Interventional Endoscopy Service Group at California Pacific Medical Center. He also has an appointment at the San Francisco VA and is Associate Professor of Medicine at UCLA. He and his group have done some pioneering work in advanced endoscopy and in general, in particular, with regards to duct access. And we're delighted to have Janak here today to share some of his wisdom with us.
First of all, thank you, Raman and the other course directors for inviting me to be part of this wonderful course. I think this is really a unique course that the directors should be congratulated on, mainly because it covers such a broad aspect of all GI diseases, and that's truly unique. A lot of courses just focus on one area, and I've personally just learned quite a bit myself. Perfect. So Raman gave me the task of talking about difficult ERCP, getting into the inaccessible bile duct. I'm actually going to focus on bile duct. Some of the stuff we talk about can be used for pancreas as well, but I think just for purposes of the talk, I'd like to focus on biliary indications. Before I get started, how many of you do ERCP? Okay, great. And how many assist in ERCP? I know there's nurses out here as well. Some in techs? Okay, so a few. So before we talk about getting into the bile duct, it's important to understand benchmarks. And, experts as well as consensus sort of documents from our national society suggest that the goal is really selective deep cannulation, obviously, of the desired duct. And for a trainee or a general endoscopist to be considered competent, they should expect at least an 80 to 90% success rate. And obviously that success rate should be higher for tertiary centers. Now, I think when you take on ERCP, and this slide I know it's in your handout, it's important to know what you're trying to do and what your expected success should be, as well as what your limits may be. ERCPs can be graded into 3 grades of difficulty, and depending on that, some experts have suggested, again, certain benchmarks about being able to accomplish that task, with tertiary centers expected to have over a 95% success in the more standard types of biliary ERCP procedures. I know many of you raised your hands. I'd be curious, how many use a cannula for initial access? Few. And how many a papillotome? Okay, so most are papillotome. That's always kind of a debate anytime you go to one of these courses and you hear somebody talk. Looking at, this includes only the randomized trials comparing these two. And in these, essentially, papillotomes functioned better for access in all 3 of these. How about guide wires? How many of you use guide wires to help inside the papillotome? Okay, so a handful. Well, do guide wires actually help access? This table actually summarizes randomized trials as well as one meta-analysis. If you look through these, most of these, either the guide wire did help or at least didn't hurt, it was the same or better, and many of these suggest a lower pancreatitis rate when using guidewire-assisted cannulation. Again, that's more of a reflection of not injecting contrast into the pancreatic duct. I like to just, summarize this wire-guided cannulation. I mean, just keep in mind that there are relative pros and cons. Certainly the evidence favors higher cannulation success and lower pancreatitis rates, but it does come associated with a higher actual financial cost. You are opening up another wire for that, and other possible risks like intramural dissection, false passages, perforations, and duct trauma. My recommendations on initial biliary access is certainly know your tools and use what you're comfortable with. I think if you're going to be performing a sphincterotomy, which is often the case, it's very reasonable to start with a papillotome. And certainly one should consider wire-guided cannulation because the evidence supports higher success with lower complication rates. But that said, just keep in mind what the goal is. Goal is ductal access with minimal trauma to the papilla and the pancreatic duct. And you should use what tool is best in your hands. And I think, just to echo, we're entering a new era of accountable care and quality outcomes. It's important to track how you do in these and track what your complication rates are. And if you have a certain tool that works for you, it doesn't matter what all these studies show. Use what gets you into the duct and doesn't cause pancreatitis. Now, the bulk of the talk I really want to talk about here is difficult cannulation. So we talked a little bit about tools for standard cannulation. What do you do when standard cannulation doesn't get you into the duct? Well, we're going to talk about 4 different techniques: pancreatic duct first techniques, such as double guidewire access, precut, EUS-guided access, and what to do if everything fails. So difficult cannulation, pancreatic duct first techniques. This involves placement of a wire or a stent into the pancreatic duct, followed by repeat biliary cannulation alongside this. There are potential advantages. The wire can stabilize the papilla. You can widen a stenotic orifice. You can lift the papilla and optimize the access. And obviously, you've minimized further pancreatic duct instrumentation. You're ready for an immediate PD stent if needed. Here's one example of that. So I have a wire already up into the pancreatic duct, and we're going to cannulate there alongside with the papillotome and a second wire. Initially, the wire goes up into the pancreatic duct, but we change the angle, and hopefully you see that there, that the wire went up that way, and we've got access. So this is the double guide wire technique that you may hear about. Maybe you've tried it as well. I think this is a very nice technique to get in. And I go to this if I once or twice get a wire into the pancreatic duct, and I think it's a difficult angle or access to the bile duct, I'll just go straight to this. There are some randomized trials on this technique. In one of them, it helped. This is the success rate with double guide wire versus continued attempts after initial failed cannulation. But in another, it didn't help. And in the one it didn't help, there was also a trend towards higher pancreatitis rate with the double guide wire technique. So at least the jury's out in terms of randomized trials. But again, I think many centers use this pretty quickly as a nice technique to gain access to the bile duct. Now, there are some potential pitfalls to keep in mind when you think about this technique. You can perforate a side branch. I mean, here's one example. You might think, oh, it's heading up towards the PD, and then obviously it goes out the side, and that's a side branch perforation. And it can also be difficult placing a wire deep into the pancreatic duct, particularly if there's some anatomical variations like an ANSA loop. Let's move on to precut papillotomy. How many of you do precut? I know there's a handful. Okay. So, there's really, a variety of techniques described which all fall under precut. Precut implies that you're trying to get into the duct without actually deep cannulation, and you're making the cut in order to access that bile duct. So probably the most common technique is using a needle knife with or without a pancreatic duct stent. This can also be done 2 ways, either incising from the papillary orifice upward, and then that's what I'd consider a traditional needle knife sphincterotomy, versus a fistulotomy, where you incise from above the orifice, and then you can either cut downward or upward in order to get access. Another popular technique is the use of a traction papillotome, a traction sphincterotome, and doing a transpancreatic type precut, or if you have a very ultra short nosed tome, that can also be used to cut open that papillary roof. And these are just some diagrams of a few of these techniques. Now, how are the outcomes in precut? And I always, when you attend large meetings and sessions, you hear people talking about precut and, oh, I always get in and, with precut. But I think it's important to think about actually and look at the data. So this is the data, and success rates certainly range from, 65% up to even 100%. And that's actually my partner at CPMC who published on that from Germany. But I think it's always important to look at, well, what proportion of the patients did they try precut? If you go right to precut very quickly, the success rates will be higher. And looking at this study, just glancing at this, some of the studies with the higher success rates of 80, 85%, the proportion of patients that they used precut was in that 15 to 30% range. But looking at the studies where precut was used very selectively, meaning that they probably really tried with other techniques trying to get in, failed, and then tried, the success rates are more modest in the 60 to 70% range. So I think that's probably a true reflection of what precut access is. I'll just show you an example here of performing precut over a pancreatic duct stent. And I think this is the preferred way of performing precut when you need to do it. If you get access to the pancreatic duct, and that stent has already been placed in the pancreatic duct, and just taking my time to precut, kind of probing a little. There we see some bile emanating from a small orifice, and then that can be accessed. But this is probably the safest way to do a precut if you're going to do it. And that's if you can get access, obviously, to the pancreatic duct. Now here's just one example I'll show you of a suprapapillary precut fistulotomy. Now this is also a nice technique when you have an impacted stone. You can see a bulging papilla, and as I press on that, you can see that the papillary orifice is actually below that bulge. So I'm not going to start cutting at the orifice itself. I don't want to even get close to the pancreatic duct. I'll just start the cut from above. And then we can see bile coming out in a moment. We'll see a nice round marble. But this is a very elegant way also to address this issue and not worry actually about the pancreatic duct itself. Now, how about comparing a couple of these advanced techniques in terms of advanced ERCP techniques? Precut or double guidewire for difficult access? Well, I've already told you my preference. I usually go quicker to double guidewire than to precut. But a couple of groups have done randomized trials on this very topic. In one of these studies, they found that the double guidewire and precut were not different, but there was a shorter time to access with double guidewire. And in another, there were also similar cannulation rates and time to cannulation. However, these groups did find a trend maybe towards either higher post-procedure amylase or even a trend towards higher or a significantly higher pancreatitis rate with the double guidewire technique. So it's just, if you use double guidewire, again, use it cautiously and carefully where you can really see that the wire's in the main duct, no trauma to side branches. You don't want to go out a side branch and create a perforation. Well, now what do we do if all these ERCP, even using advanced techniques, fail, such as, including precut or other advanced techniques? Well, for most of us, the usual option has been to consider an IR-guided rendezvous. But what I'll throw out is for the pancreaticobiliary endoscopist who does interventional EUS, a very reasonable option is to do an immediate intraprocedural EUS rendezvous. This is where you use EUS to puncture into the biliary system. Keep in mind, we're talking about bile duct, but the same sort of pattern can be applied to the pancreatic duct, and we don't have an option for that with IR-guided access. Following that puncture, wires advanced across the papilla, and right at that same session, immediate ERCP can be performed. I'll give you an example here. This is a mass, ulcerated mass I had a few years back in the second portion of the duodenum. And I think anyone can see that, well, this is just difficult. You can't see even where to access. So I use EUS. This is a transgastric puncture. I get an anterograde cholangiogram. Our groups kind of coined this term EUS-guided anterograde cholangiography as a, to show the difference in the access as compared to retrograde. And we can grab the wire, and now we can see where it comes out, obviously, and immediately over the wire, a stent can be placed. But this can all be done in one session. And actually, our routine at our center is to consent these patients at that same session that if you need an ERCP and we can't get in, we will, we can use EUS-guided techniques to help if needed and if we see fit. Now, there's a lot of series, including our own large series on EUS to facilitate rendezvous after ERCP. The numbers I'm quoting here actually focus on biliary rendezvous, but many of these series combine both biliary and pancreatic rendezvous. Just to summarize these, summing them all up, it's successful in about 85%, and the complication rate's about 8%. Now, one group actually, there's a very interesting study, a group from India looked at outcomes of EUS rendezvous versus precut access. And they actually had a historical time period. They have actually a very world-renowned expert biliary endoscopist as well as good interventional endosonographers. And they looked at a time period when they weren't using EUS routinely to get access, and then looked at another time period where they didn't use precut and tried only EUS. And again, I apologize. I don't know why that's happening. But their results were very interesting. They found that their first session success rate for access was greater with EUS rendezvous compared to precut. They also then looked at overall success, meaning some of the precut patients they brought back at a second session. But I don't think that really constitutes a success. I mean, to me, if you can't get into the duct at that first session, that's a failure because the patient then would then need a second session to get in. And they found no difference in complication rates, although the types of complications obviously were different. And essentially, there was no pancreatitis in the EUS rendezvous procedures. And that makes sense, because you don't really touch the pancreas to get access to puncture into the bile duct and thread a wire down. This slide, I apologize, is not in your handout, but I wanted to include it. This is our own data. We actually looked at a series from our center where we've been using this clinically, we've clinically incorporated this into our practice. And we looked at Center A, which is our center, compared to Center B, which has a very good biliary endoscopist, but they don't have EUS available there. And we looked at 2 time periods comparing a large series of patients. We had standard cannulation success was similar at both centers. Advanced techniques, the rate were an advanced technique, which we defined as precut or some sort of EUS technique. The overall advanced techniques were attempted at similar rates, but clearly we actually almost did half and half in terms of precut versus EUS interventions. Technical successes for precuts were similar at both centers, and obviously one center doesn't do EUS, but our EUS intervention success rate to either get access, most of these were rendezvous procedures, but a small proportion were direct drainage procedures as well. But that success rate was 95%. But I think what really I wanted to highlight is, the overall therapeutic biliary ERCP failure rate was significantly different, 1% failure rate versus 4.5%. Now, you might say that's not a big deal, but, in 100 patients, if you can decrease the 4 to 5 failures to only 1 failure, that can make an impact for those patients. We also looked at overall success of EUS interventions versus precuts from both centers and found that EUS was more successful, and it remained successful even if you include second attempts after initial precut failure. And unfortunately, this was a retrospective study, so it's hard to really collect definite complication rates from both centers, but at least in the limited data we have, it wasn't significantly different. Now, one thing I want to just show you here, too, this is a nice video. Sometimes you can't get to the papilla. I mean, in malignant obstruction, 10 to 20% of patients will actually have gastric outlet obstruction as well. So you try an ERCP, and it's just impossible to even get to the ampulla or get in a nice position. This is also a nice area where EUS can help. This is an example of a case I did a direct EUS-guided therapy. We couldn't get there, so I do an anterograde cholangiogram. We'll thread a wire down. This is what the IR radiologist would do otherwise, but usually at a separate session. Initially, we couldn't get the wire across, so we follow this with a cannula across. And obviously, at this point, you're committed to doing something. then with a little effort, the wire can get across the stricture. And then the same way an interventional radiologist might do, usually at 2 or 3 sessions later, because usually I've never seen them go straight to putting in a metal stent, but we've favored just going ahead and putting this in at that first session. And this is an anterograde placement of a stent. So, we just push the stent across in the same position we would have pushed it if we had gotten retrograde access. Now, others have described also direct drainage using EUS-created hepatogastrostomies or choledochoduodenostomies. And there's a lot of debate among interventional endosonographers of what's the better technique or not. But right now, with these tubular stents, at least our group has favored that if we can get across the stricture, that tubular stent was meant to be placed across the stricture. So we're just getting it there using a different format. Now, I just want to mention a few other options for failed cannulation. There's studies on all of these. One option is to call in a second, more experienced endoscopist. So if you're in a group and you know one of your partners has more experience, it's worth maybe calling them in and seeing if they can take a shot at it. In one study, this increased cannulation success from 88 to 96%. There is data out there of doing an ERCP again, the same operator doing it on a different day. And usually, in many cases, this is involved actually doing a precut, you can't get in, you bring them back a second day and you do get in. But successful access has been documented in 88%. And obviously, a third option is always to refer to an expert center where expert centers, tertiary centers are expected to actually have rates at least 95% or greater. And keep in mind, it's not a negative against necessarily your experience to do that. When these patients come to an expert center, often advanced techniques like precuts, in this era, EUS rendezvous, they're used in the majority of these patients. So just to summarize, I think we've made all these points. For initial cannulation, evidence supports using a papillotome with a wire. I think it's important to understand what you're trying to do and know your own limits. But bottom line, for initial cannulation, I would really stick to using what works for you. I've actually, for a while I was using papillotomes with wire. I've kind of migrated back to using very tapered type cannulas. I've just found that I've got higher success with that. But it's important to track these for your own practice so you can actually not only report if needed, but you can develop and optimize your own technique. In terms of difficult cannulation, pancreatic duct first techniques, those are the double guide wire alongside a PD stent. We showed a case of that. Keep in mind the precut techniques, and when you do precut, I think it's still important to think about a pancreatic duct stent and indomethacin in this era, especially for those high-risk patients. Obviously the others we just covered. In the interest of time, I'll finish right here. This is just some pictures of our unit and our team. It's missing Dr. Hammersky, who joined our team last summer, trained here, so I got to update the photo. I do think this is very much a team effort. So for difficult endoscopy procedures, we actually use a dedicated team of nurses who all they do is this. And I think that improves our own success rates. Thank you very much.